I know some students they love the tables, kind of like a quick review, that's gonna be helpful. Talking about salivary glands, the muscles of the tongue, extrinsic and intrinsic. The extrinsic, they move tongue from side to side, in and out. So you stick your tongue out or you pull it backward, those with the extrinsic muscles. And intrinsic, it alters the shape of the tongue. So when you roll your tongue, you change the shape of the tongue. That's due to the intrinsic tongue muscle. Taste buds. We didn't talk about the taste buds. Maybe today I'll bring the tongue as a slide. You saw the small intestine. I can bring them one at a time. So I can bring digestive today, small intestine, large intestine, tongue, and those three enough for you. I'm not going to deal with the stomach because we have a model for the stomach, but make sure to know at least the three for digestive system. Taste buds, we'll be able to see them today when we have the tongue slide. We talked about lingual lipase, remember? Where we said the tongue has an enzyme, and I put it for you. What it says here? Try into what? Die. Mm-hmm. So if you like review, it's a good table. It's from other source. Pharynx. We had the same diagram back in respiratory, if you remember the same thing. Here's the epiglottis. You can see the larynx is here, the concha, which is superior, middle, inferior. And you can see the opening here of eustachian tube or auditory tube to minimize the pressure in where? Why we need this opening from auditory tube?
For the middle ear.
Middle ear, exactly. Because it's a closed cavity. Yeah, you have a drum, of course, and then you have a cochlea. See, so it's kind of like closed. So we want to release that pressure. So you're going to see auditory tube coming from middle ear, opens where? Nasal pharynx. Okay. We talked about this. Same thing. The pharynx, esophagus. Okay, I want to talk about the esophagus because most of you heard about esophagitis. It's very risky and can be deadly. Not just risky, it can be deadly. If you want to ask me why, first, location of it is critical. You have a trachea in front of the esophagus, and we've seen some that they ruin the lining, which you can see it here. What it says, the lining. So that's a good layer, correct? When I say stratified squamous epithelium, we don't need cilia here, we know that. Because why you need cilia? Gravity will bring everything. And it's not kicking out dust or things like that. So non-keratinized, because it's not like the skin. Skin is keratinized, stratified squamous. We don't need keratin here. But if you think about it, we've seen that some, this layer got damaged. And what is the most important thing that can damage this layer?
Acid.
Very good. Acid reflux. And if you live with acid reflux and you don't care, you don't treat it immediately, and we have over the counter even. Yeah, you don't have excuses telling me, oh, I have to book with the doctor appointment. No, it's over the counter. If you live with this acid reflux for a long period of time, this protective layer that we have, which is made of 3 layers, start to be eroded gradually. And now, especially the part which is the last part of your esophagus when it enters the stomach, that's going to be the maximum damage. And you start having esophagitis. And when the esophagus inflamed, you are risking, anyone knows? Something called Barrett's esophagus. Barrett's esophagus is pre-cancerous. That's the bad news about it. So now we're dealing with acid reflux, didn't take care of it, end up with a cancer. And cancer of the esophagus is deadly. Yeah. Ask any doctor, they will tell you, okay, it's cancer. There is a lot of important structures here, vital. You have artery, you have veins, you have nerves, you have glands. Imagine if you have cancer, what could happen? Sure to them. So for that reason, if you have any reflux, that's why they call it GERD. Anyone heard about GERD? Yeah, we always. So GERD is gastroesophageal what? Reflux disease. That's what they call it. They diagnose you with the GERD. You have to be careful. Follow up with the doctor. They take biopsies to rule out any Barrett's esophagus. Because if they tell you, oh, you have Barrett's esophagus after taking biopsy, they're going to tell you it's precancerous. And we have to see you after 3 months or 6 months and so on. So you need follow-up in this case. So it's a big headache. Yes, it's precancerous, but they want to know that it's not going to advance into cancer. So you have to always check up with your doctor. Okay? So this layer, want to keep it in good shape. Okay? Treat any acid reflux and know the cause of it. It could be hiatus hernia, it could be any of those things that causes the problem, or weakness of which sphincter? What's the name of the sphincter at the end of your esophagus? Because you need to also study those on the diagram, I think, coming Thursday. No one looked at the diagrams? What's the name of the sphincter?
Oh,
The stomach. No, the one when the esophagus in cardiac, the top one. Yeah. You see when
Which one?
here we have the stomach here. Okay, you have an opening here, and you have an exit, inlet, exit.
Mucosa with
Cardiac, and what? Pyloric. Now, if you have weak cardiac, what's going to happen when the stomach contracts? Reflux. This should tighten when the stomach is doing the digestion, the contraction, with the 3 muscle layers, not 2 like your intestine. We have the 3 muscle layers of your stomach. Yes, inner circular, outer longitudinal, but add to it one called oblique. You see? Serosa, same thing, everything is the same. But it has 3 layers in the muscularis externa, which you add the oblique on top of inner circular and outer longitudinal. So if this is weak, of course, now back up on your esophagus, all the acid. Unfortunately, there is no mucus like to protect your esophagus. Yes, it has a powerful lining, epithelium, but no mucus to protect it like your stomach. Stomach, it has a mucous neck cells. We're going to see it, and I'm going to talk about it, and so on. Now, the rest will be the same. Look, submucosa. So we're done with the mucosa, submucosa. Inner circular, outer longitudinal. Repeat the same thing. Instead of serosa, you have what? Adventitia. Because there is no peritoneum. You're going to ask me why they changed the name. Where else I don't see serosa? Rectum. Rectum and anal canal, of course. All the last part, you do not have serosa. The rectum, if you look, yes, it has all the layers that you studied, except you replace serosa with adventitia. So I'm bringing you those differences. So don't be confused and say, oh, we learned it serosa. I said no serosa in esophagus, no serosa in rectum. And of course, no serosa in pharynx. Before the esophagus, we have pharynx.
We have a lot of people with like gastrointestinal issues that come into urgent care. And they always treat it with like a GI cocktail. What is that doing exactly? Have you heard of that?
GI,
Cocktail?
they had
It's
GI
like-
cocktail.
No, the
they-
doctor
they-
treats it with a GI cocktail, they call it, it's like lidocaine.
To treat
and
the
naloxone.
acidity, yes. It has a basic fluid, like alkaline, and then that's gonna neutralize immediately the acidity of the stomach. So they call it GI cocktail. So if you wanna ask me what's in it, it's the same as Maalox contains. It's aluminum hydroxide in it, magnesium hydroxide. It's a cocktail of all those alkaline that we can give it to them and neutralize the acidity at the moment, you see. So yes, we've seen that, and it should actually help because it's local. Yeah, GI cocktail, it's local. So it's kind of like put Band-Aid on the wound, exactly. So that's the esophagus. So we know now the adventitia, why they call it. Yeah, replacing cirrhosis, exactly. Deglutition, which is the swallowing, okay? As long as the bolus in your mouth is voluntary, we call it the oral phase, you can spit it out. The moment the tongue pushed it and touched your palate, correct? It's on autopilot, involuntary. You cannot change your mind. Why? Because the moment it touches your throat, pharynx starts contract immediately. It's a reflex. Okay? So the pharyngeal is involuntary, and of course, after that esophageal phase, because it's gonna go down to the esophagus, it's also involuntary because of the peristaltic movement. So that's exactly. What else should happen? We should immediately, when it touches your palate, throat, what's gonna happen? Epiglottis should close. Yeah. We said it's elastic cartilage immediately. If it closes slowly, you're about to choke. That's exactly what happened. You start coughing, and it's delaying, we call it. Sometimes it happens. So the moment it touches this immediately closes and pushes it down to the esophagus. So pharyngeal and esophageal phase. Then it will go all the way down. And don't forget, we have two sphincters of the esophagus. The upper esophageal sphincter all the way up. You see, that's the esophagus. So we have here the upper esophageal sphincter, and we have the lower esophageal sphincter. What's the other name for it? The lower esophageal sphincter. Cardiac. So open parenthesis and put LES. Lower esophageal sphincter is the same as what? Cardiac sphincter. So don't be confused when you read it. And that's the esophagus. So upper and lower. That's why they put you here lower. So it is the same. It is cardiac sphincter. And then the sphincter should relax, of course. If it's contracted, you're going to have that pain immediately. But the good thing, a reflex will relaxing it, enter everything to the stomach. When the stomach starts contracting, the opposite is going to happen. We're going to close this, and of course, pyloric. Because you want to mix with the acid. If I don't close it on both sides, I'm not going to be able to mix that bolus that end up in my stomach with the enzymes, with the acid that is in the stomach. Makes sense? Now, if this is loose, when the stomach is contracting, you're gonna have a reflux, and that's dangerous. Because imagine the acid of the stomach, guys, pH is 1.5 up to 2. That's severely acidic. And I remember one professor told us, I remember, he said, if someone has repeated vomiting, okay, and he's vomiting on cement block, and I'm talking about repeated, you know what's repeated? that's the upcoming, gonna be more acidic than the first one, correct? He said it creates holes in the cement. And we were like, do we have this in our stomach? pH 1.5 to 2? And it was true. Just to show you how powerful is that acid and how it can damage your esophagus if you don't treat GERD. So GERD should be treated as soon as possible, as I said. Okay? But the good thing is the stomach can digest itself. Why? Because of the mucus. It has a mucus layer strong. We have mucus neck cells. I'm going to show it to you. A lot of that mucus cover and coat the lining of the stomach. So it's not going to harm the cells unless there is an ulcer. So an ulcer is a different story, okay? Why some people having ulcer and why some they don't? Here is the two things I want you to understand. If you have an ulcer, you make too much acid, too much HCl, which is hydrochloric acid. And that's from parietal cells. That's one of the things we don't know. You inherited that problem. They're so active, they're producing too much cell. Or, what's the other possibility? You produce less ammonia. Makes sense, guys? Well, ammonia is NH3. Ammonia is toxic, but yes, we produce it from the lining. But the good thing, it helps us here. How ammonia can help and becomes ammonium, which not going to be harming the stomach, of course. It traps what? H ions. So NH3 trapping the H ions and become NH4. So I am minimizing the H ions, and H ions indicate acidity. So if you have less of the ammonia, of course, you're prone to what? Gastric ulcer. So either you make too much acid or too less of that ammonia. You are prone to gastric ulcer. This is what we found. So it depends on your condition. Yeah. But we have treatment. That's the good news. You know, we have treatment for this condition and prevent the gastric ulcer, and even treatment of the gastric ulcer. So let's go. This is kind of like a review, same thing. Okay. Little bit of mucus release in the esophagus, but not significant. It's just lubrication. I'm not talking about the stomach here. Stomach is different. You have different types of mucus cells, which I'm going to show it to you in a moment. But this one, I think it looks the same, similar to the quiz that we're going to have on Thursday. Yeah. Can you see the 3 layers of muscles? Now you're going to ask me why the muscle having 3 layers and the rest of my intestine, even esophagus, having 2 layers. Here is what we found. Stomach can do a lot of movements. It can go this way, and it can go back and forth, and it can go like this. And that's why it needs 3 layers of muscle. It needs to mix a lot of those contents before sending them to the duodenum. So that's kind of like unique for the stomach, because it has added oblique, you can see it here. So the 2 layers are the same, but the deepest one is the oblique. I have a model for the stomach, if you like today to look at it. So I'm sure one slide of the tongue is going to be immediate, you can look at it, but the rest of the time, benefit of looking at the stomach and study all the things that you see here on the diagram. We have rugae, or you call them rugae, whatever pronunciation is correct. So rugae, which are folds in the mucosa, you can see them here, see? Those actually help to increase surface area. Why? Because when they expand, they can accommodate more of the food. Stomach can accommodate about half gallon. Imagine, half gallon easily by expansion because of those ruby. If you don't have them, it's not going to be able to do that. So increased surface area, allowing also more of the enzymes to work on particles, digestion of course, that would be helpful, and expansion. So two things here.
When they do the bypass to lose weight, what they could,
What- Yeah, of course, they cut. I would recommend the sleeve operation because in the sleeve, they just go like this and kind of like get rid of that part. Yeah, they just fold it, staple it, and you have a small stomach. So you're gonna eat gradual, and you see a lot of loss of weight, especially at the beginning, because you're not eating a lot. They start you on liquid. The other one, I don't recommend it because they call it gastric bypass surgery. They actually cut about 2/3 of that stomach and leave it in your tummy. Of course, they're not gonna take it out. They leave it, but they connect the rest with the intestine, and sometimes it does what is known as dumping syndrome. So everything goes directly, stomach will evacuate it immediately. So some of them, they're gonna have indigestion, sometimes, lack of nutrients absorption and things like that. So the most common nowadays is the sleeve gastrectomy. Ask about sleeve gastrectomy, which kind of like becoming common here. Most of you heard about it, the sleeve gastrectomy. I know some they did the gastric bypass. I'm not saying anything. They function good, but if you want recently with the research, they recommend sleeve gastrectomy. Just folding that part and then have a small stomach. However, if you don't take care of it, it can expand. That's a problem. Yeah. So some people they lost weight and then went into depression, stopped eating, ruined what they did. Yeah. So be careful with that because it can happen. So that's about it. And we have here the antrum. Don't forget. Okay. Pyloric antrum and pyloric sphincter and the canal here. So start with antrum, canal. And they call it J-shaped stomach. It looks like the letter J, correct? See? Like a J-shaped stomach. With the fundus, see the fundus curve? What else has fundus, which I mentioned today? Uterus. Uterus. Remember when we talked about it? And then body, you see? And pyloric antrum. And then end up with a sphincter that you can see it here. Both sphincters are smooth muscles. Smooth muscles. So all sphincters are smooth muscles that we have in the body, except all the sphincters are smooth, except what? Who remember? Two. So when I write them down, external anal sphincter. The one when you go to the restroom, you control yourself. You give the command for that. It's a skeleton, not smooth. External anal sphincter, external urethral sphincter. Those two, exception. Any other sphincter that you have in your digestive here, all of those are smooth. Okay? So if I ask you the internal,
Please, because I don't know how to spell it.
the spelling, okay.
Sorry.
So
So both
external.
the urethra and the anal are skeletal?
The external, I put here line, anal sphincter, and the external urethral sphincter. Those are what?
Skeletal.
Skeleton. Okay. So let's see now. So pyloric, smooth, and cardiac is smooth. You see here when you open the stomach, that's what you see. You see the rugae or rugae help in increase surface area for, of course, absorption as well as digestion and expansion of the stomach. Here is what attached to this. Who remember?
Greater.
Lesser omen, correct? What attached to this? Greater omen. So make sure those could be on what? Final. So the function of the stomach, I want you to pay attention. Also questions possible here because we're gonna have enzymes. So write them down. I think unless I don't have a table. Oh, we have table. I have a table. But put them on a piece of paper, stomach. You can put like this. So mucus neck cell produce mucus. Okay, that's the first one. Mucus neck cells. And we just talked about parietal. So put it also, parietal cells. Put two things produced by parietal. The first one is HCl, okay? And the second one, intrinsic factor or IF, okay? So IF or intrinsic factor, intrinsic factor. So this is very important here. Then put chief cells and produce pepsinogen. Pepsinogen is inactive protein and should be activated to work. It should be converted into pepsin to be able to break down the protein into amino acids. If it's not activated, it's not gonna work. So which one gonna do the activation process of pepsinogen into pepsin? They're neighbors, the hydrochloric acid. So I can put here HCl from where? Neighbors. Neighbors. Parietal, of course. So those are very important. It's kind of like they collaborate together. Okay, get me hydrochloric acid, I can take care of what? Pepsinogen. That's exactly what they're doing. So if you don't have this, by the way, you're gonna have problem when you eat meat. Because it's all about this, the acid. And we know how the acid is important, but we don't want too much acid. Again, too much acid, ulcer, gastric ulcer. So it's kind of like we need it in the optimum level all the time. All right?
Does it also do lipids like the gastric lipase?
Which, yes, it also can activate the gastric lipase. Another, function, if you like. It can do activation to the gastric lipase, yes.
And the first one in there, is it saying mucus neck?
Mucus,
The first
mucus neck.
neck.
Yeah, like neck. Mucus neck cell. We have also something called G cells. Okay, so I can erase those now. We're done. What causes the ulcer, remember? Too much or less of ammonia. So this one produces gastrin. And gastrin increase motility, gastric motility. So kind of like a hormone, like doesn't have ducts, released into the blood and act on the stomach. Remember when we said autocrine? I would say this is a good example. It released and act on the stomach. So increased motility and increased secretions. And we need this. We need help here, we need a push. So it comes from G cells in the stomach that produce gastrin. Okay. We have another one that also can help. Okay. So I'm gonna put it for you here, and then we found certain cells called chromaffin. So put with the CH, chromaffin. Chromaffin cells. So chromaffin cells, they produce histamine, and histamine actually does the same as gastrin. That's why make an arrow and put the same thing. They do the same. Histamine also can be released when you have allergic reaction. Remember basophil, we talked about it, how they produce that histamine when we talked about the blood. Histamine, you have enterochromaffin cells in your intestine. Now you want the proof. Anyone heard about those who having allergic reaction with hives? Ask some of them, they will tell you, we also have diarrhea. Now it makes sense to you. Why? What histamine is doing. What histamine is doing, guys. Yeah, and when you increase motility and secretions, you're gonna have diarrhea. You're gonna have increased peristaltic movement. We've seen that happen. Those who develop those hives, it's also accompanied with diarrhea. And that's due to histamine released from the intestine, as well as the stomach, as you see here. So chromaffin cells are responsible to produce histamine. Where else we have it? In your skin. Yeah. That's why you see the hives. Yeah. Okay. The HCl, we just talked about it, how it activates, it's written for you here, gastric lipase, you see? And now we're gonna go back to IF, intrinsic factor, and its importance. IF, stomach is very important. IF, we found it couples with vitamin B12 from animal products that you eat, vitamin B12, anything from animal product is rich in vitamin B12, all types of meat, fish, milk, cheese. Yeah. So vitamin B12, in order to be absorbed, it has to be first coupled with what? With IF. It's kind of like a bonding, and they make a complex. You see, when they bond together, they call it vitamin B12 IF complex. And now it becomes a complex protein with that bonding action. If you don't bond them together, you're not going to be able to absorb vitamin B12. So who is at risk of having vitamin B12 deficiency, which classified as pernicious anemia? Vitamin B12 deficiency anemia. That's what we call it, pernicious anemia. Who is at risk of having low or vitamin B12 deficiency?
The elderly.
Elderly, not as risky as someone else.
So somebody.
I would say elderly, yes, I accepted the absorption would be less because
Vegan?
of the age. What?
Vegan? Vegan people?
You have a storage of vitamin B12 in the liver
Yes.
that can last for years, just to let you know. Vegan's not gonna be affected.
People with cirrhosis and stuff. Like, you talking about like who would,
Alcoholics?
so. the
Yeah,
liver.
The liver, if the liver is damaged, but the one we just talked about a while ago,
Diabetic people?
gastric bypass.
Ah.
How much? We said 2/3 of the stomach is gone. Where are you gonna get IF? Now you're gonna tell me, oh, I'll give them oral vitamin B12. It's not gonna work. It's not gonna work.
So
That's
they have
why
injections, right?
injection or
There's injections and then there's
under the tongue,
yeah, the lot.
sublingual.
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 So after operations like this, Whether it's sleep, gastric bypass, we have to take care of them and put them on vitamin B12 supplements, either injection or what, under the tongue, but not oral. They're not gonna benefit of oral. Yeah, most of the stomach is gone. Yes,
So why can't they use the storage in their liver?
because the moment you swallow the food rich in vitamin B12, correct? It dumped with the IF, as I said.
No.
Are you gonna wait for the storage to work? No, stomach is busy, it's gonna push everything. So we need that click in the stomach, all right? So we understood now the stomach, guys. It's very important to understand. So again, if your parietal cells is so active and produce too much of this, you are prone to develop gastric ulcer. Or the one I erased, if you produce less ammonia from the lining, what's gonna happen? You are prone also of developing gastric ulcer. Because ammonia trap H ions. And if you have less, that means H ions gonna be free. And H ions indicate acidity. What is the proof that H ions indicate acidity? What I said, every acid on earth, what they share. H ion. Here is example. Hydrochloric acid, sulfuric acid, nitric acid. What else? Phosphoric acid. Vinegar in your kitchen. Look how many H. What's the common thing here? H ions. Every acid on earth has H ions. So if you produce less of that ammonia, it's not gonna trap the H ion, because I showed you how it trapped it. So less ammonia or more acid can, you'll be prone to develop what? Gastric ulcer. Okay, so now I want to show you some of those cells since we talked about them. This is actually same layers, except what we said for the stomach, triple layers, correct? So triple layer, and we can see here 1 and 2 and 3. See, 3 layers. And this is for the stomach, and I can see oblique, circular, longitudinal, and then the serosa we can see it.
That's 4 layers?
Yeah, 3 layers. 1, 2, 3. Yeah. 3 layers. Step. Inner circular, outer longitudinal, and oblique. Oblique is the deepest one. You see? Yeah. You start here, and then the deepest one will be oblique. Very powerful. This one. Now you can see here the. Is there villi? If I ask this question, is there villi? No. Look at the surface, straight. If there is villi, you're gonna see this notched out, like the one you saw in the small intestine. But those are gastric glands hidden. You see how they're hidden? They have openings. That's the opening. We call them gastric pits, P-I-T-S. Openings of the gastric glands. This is the opening, another opening, and so on. And they release all the secretions from mucous neck glands. They point to them here. We have also surface mucus cells. Look how many. We have mucous neck cell and we have surface mucus cell. Look how many mucus we need to protect the stomach from that acid. 2 types. And then you have glands. And same thing, repeat the same thing, muscularis mucosa and submucosa, you can see it here, the white color, we're rich in blood vessels, then the 3 stacks of muscles, then the serosa. Okay, that's about the stomach. We don't have a slide for it. Yeah, we don't have a slide. Here is the surface mucus cell. What it says, secrete mucus. Mucous neck cells produce mucus. That's gonna add up. And look how they're kind of like lined up. And then parietal, you see, here is parietal. Here is chi. Here is G. And I explained to you what each one does. what each one does. Any question on the cells of the stomach? Okay. Now, yes.
Do we need to know the D cells versus T cells?
You don't need much detail for D cells, somatostatin. We have a lot. We have ghrelin. If I want to go into that, that's going to be deep physio. For you guys, if you just know those, that would be more than enough. We have ghrelin, has something to do with the appetite. We have somatostatin. We have other cells, but that's going to be in pure physio. I just want you to know all what we talked about. All right? So here's parietal cell. I want to show you. We just said it has to produce hydrochloric acid. How it produces hydrochloric acid? Without pumping the H ion, without pumping the chloride ion, you're not going to be able to couple them, correct? So let's see here. I can see the chloride, and you have chloride in your body, we know that. So it would be pumped. Here came from the blood, like you see here, and then pumped into the lining. So that's the lining of your stomach, the green one. And now the H ions also would be pumped, and that's through this parietal cell. That's only one parietal cell. And then it will be coupled with a positive negative, anion cation. They hook to each other and make the acid. Why I said to understand basic, if you remember, I said this course is very important because if you don't know this, you're not going to understand when they talk about pharmacology, when they talk about medications. There is a group you're going to study later on in nursing program. They call them PPI. Look at the abbreviation. Proton pump inhibitors to treat any gastritis, esophagitis even, and gastric ulcer. Who can name some of the over-the-counter? Because previously it was prescriptive, and now we can see them in Costco, we can see them in CVS.
Pepto?
What's that?
Pepto?
No.
You said, what you talking about, like? What
I talked about a group called
Proton-
Prilosec. Very good. Yeah, Prilosec is the one, guys.
Proton pump inhibitor.
Proton pump inhibitor. You saw this over the counter, correct? Yeah. So you see for 2 weeks or 1 month, whatever dose you are getting to treat any gastritis, gastric ulcer. So we use actually this for treatment. But if you don't understand why we call them proton pump inhibitors, you're gonna forget it. You're gonna forget it definitely. This group will be gone. But again, what is proton? Positive ion charge. The term proton means positive. Pump.
Pumping the proton.
Here is the pump, correct? And I want to inhibit it, correct? So it's inhibiting the pump of proton, which is the H ions because it's positive, and inhibit it from coupling with the Cl. So I am minimizing the acidity. And that's why they call them PPI.
Yeah,
Proton
reducing
pump.
the
Yeah.
stomach acid that's
Exactly.
formed by the glands.
So if you know the basic, when you get into pharma, you're gonna follow up with them.
Yes.
Why they call them like this. But you have to understand the basic, which is the physio behind it.
Now,
Yeah,
I got
yes.
a question. So I know with PPIs, I know when I've had like patients in clinicals, you have different. I know they be on like a little, they be like Prilosec or different PPI and everything, and then they added with like something with lipids, like atorvastatin, like one of the statins. Is that why do they do that?
Here we can add them even to antibiotics, which is caused by bacteria, because one of the gastric ulcers is caused by
It's a little chicken.
Anyone heard about this bacteria? How about this
H.
bacteria?
pylori, which is a bacteria that.
This is a powerful gram-negative, and by the way, maybe I would say majority of us has the bacteria, but it's not causing injury. In some, we don't know why it becomes active and start digging in the mucosa because it's a gram-negative. When you study micro, they're gonna talk about gram-negative and how powerful. It's like E. coli. Remember E. coli? It's a gram-negative. So this can dig in, produce some of those enzymes that can ruin the mucosa and causing what? Gastric ulcer.
That's what I was gonna say, when the levels get high, doesn't H. pylori is the main reason why ulcers
Yes.
begin to happen?
Exactly.
The duodenum, ileum.
And that's why I always tell the students, if over the counter doesn't work, go see a doctor. Why? Because before we were doing that breath test and blow in a bag and send it to the lab, it was a hassle, to be honest. Right now, they have a blood test where they can take your blood, send it to the lab, and tell you if you have H. pylori, which is much easier nowadays. So I would say, if over the counter doesn't work, even with Prilosec, because you're gonna tell me, oh, you just said Prilosec is effective. But if the cause is bacteria, they combine it with tetracycline, which is antibiotic. So they give you even triple therapy. Yeah, there is a regimen, multiple regimen that they give you 3 different. One of them is this Prilosec, but they have to combine it with antibiotic, and you have to take them for 2 weeks. They said 10 days to 2 weeks just to heal or to kill that bacteria. And by the way, I had it. I went through that. Yes, I had H. pylori because I noticed. I took over the counter, and it just happened sudden. And I never complained of any acidity in my life. And then when it happened to me, I said, "Oh, maybe from the food. Maybe okay, take over the counter." And I tried Pepcid, I tried Prilosec, I tried Maalox, I tried everything. Still didn't go away. Went to the doctor, and then took my blood, and I had it on my answering machine at that time, and it say positive for H. pylori. You have to see the doctor to prescribe what? The triple therapy. And I took the triple therapy, and it went away. This is a good experience for you to see that do not ignore any gastritis condition if it doesn't go with over the counter. Yes.
I was just gonna say, you go to a naturopath and they do those GI map testing, right? And they come
Yeah,
back and they
sometimes.
see the fecal. But then if you go to the doctor, like you do a blood test, right, or a fecal matter test. Because I had somebody that said I had H. pylori, and I don't have any symptoms of it.
Because I said at the beginning, yeah,
and then
you
I
may
went
carry
to
it.
the doctor and it came back negative. So
Uh-huh.
why would one say, like,
That's what my mom was
yeah.
One said a positive.
So one said,
Okay.
like, you did like a GI map where you go to like a national.
GI map, I said 90% of us having this bacteria in the stomach. I said it at the beginning, but in some, I had it before, correct? But
Yeah.
it becomes active for some reason. We don't know why.
But
So
the
when
GI
it becomes
map was
active, you have to be
positive,
careful.
And the doctor's test was negative.
Well, because everyone has
Because
the
when we
same
do
idea.
specific blood testing is different than GI mapping. GI mapping giving you, you have H. pylori.
Yeah.
But if you don't have signs and symptoms, it's not gonna benefit me.
Yeah, it's like E. coli, right?
Yeah, is
Yeah,
it?
because you have that too. Because that's why I was like, oh, she's like, you have a high H. pylori. And I go to the doctor, he's like, no, you don't have any H. pylori. I'm like, I don't even have.
No,
any
he answered you, you don't have an active H.
Yeah.
pylori. Don't understand it. You had it in the test, but it wasn't active. You see, that's the difference. I want you to understand that you may have H. pylori now, which is more of us having it, but it's not active. So you don't have signs. The moment you're not having any relief with over the counter, as I mentioned, see a doctor. Because treatment was magic, guys. It went away, believe me. Yeah, I continued it for 10 days at that time. I remember 10 days he gave it to me. And it was a combination of 3 medications. It went away completely. I never complained after that. And we're talking about 10, 15 years ago. Never happened to me after that.
What they give you, like tetracycline?
Tetracycline and penicillin and Pridosane. Yeah, so combination of three.
So why would you give two different antibiotics?
Gram negative. You see? Good question. Why you give two? Gram negative. Because this is a powerful bacteria. Yeah. All right? For gram positive, one is fine, but this is gram negative, unfortunately.
Do you have to see the gastro?
No, it was regular doctor. He didn't even.
Only reason it
A
goes to the
PCP
ulcer.
can solve the problem. Don't worry. But you have to tell them, I tried over the counter and still I have it. So he can take the blood and send it. So that's about the pump, guys. Here is a good summary for what we said. If you love tables, pancreas, we can talk. What's number is that?
34, this one?
Yeah, we can talk about the pancreas. It's good to know about pancreas because we mentioned pancreatitis. Number one cause of pancreatitis is alcoholism. Number one cause of hepatitis is also alcoholism in the United States. So we have to keep this in good shape all the time. And the pancreas is having a head, body, and tail. And sitting where, guys? Look at the. So here is the pancreas. And that's the duct. The pancreatic duct open in the duodenum, which is the first part of your small intestine. You see head, body, tail. Like this is where you're gonna find it. So when we dissect the fetal pig, you have to look at the stomach, locate what duodenum, and you see the gland. If you follow the anatomy, you're not gonna make mistakes because it's just a gland. That's what the pancreas. Is it exocrine or endocrine?
Both.
Both. Very good. Because of pancreatic acinine produce the enzyme, and islets of Langerhans produce the hormones from alpha, beta, and delta. And we mentioned this before. Here is the main pancreatic duct or duct of Wirsung. Wirsung, that's the name of the person who we honored his name. So pancreatic duct is in the center. This is the main. We have accessory pancreatic duct. I think you can see it coming from here. Just accessory, they call it pancreatic duct. You can find it on the diagram because this is kind of like more from outside. Here is the head, here's the body and the tail. Very delicate structure, can be inflamed, especially from alcoholism, as we mentioned, can be inflamed from pancreatic stones. We've seen some, actually, they develop those stones, and sometimes it's due to increase of a hormone that you studied before. And we just had endocrine system midterm, if you remember. What hormone increased calcium in your blood? Parathyroid, very good. So if you have excess of PTH, that means your calcium level is high in the blood and tend to calcify as stones in kidneys, in pancreas, and those are soft tissues. They cannot handle the amount of calcium deposited. So we've seen some, they have those stones in the pancreatic duct and start backfire, make a pressure on the tissue of the pancreas and inflame it. So we've seen this. We've seen it from alcohol, as I mentioned, or sometimes cancer. Smoking can also be contributing to that. So a lot of factors that can cause, or cancer, maybe metastasis from somewhere else that hits the pancreas. So as you see, it's a gland. And don't forget, it makes what it says here. Baking soda, yeah. Baking soda, that's sodium bicarb. Baking soda. And that's neutralize the acid immediately. Because acidic chyme gonna leave the stomach, powerful. 1.5 to 2 pH. So you need to dump plenty of the sodium bicarb, and they tested the pH of this one and it came up 8.5. And that's gonna be enough to neutralize the pH of 2 or 1.5. You see
The
the
pancreas has an 8.5 pH? Like
yes,
in general?
yeah, because of that, because of sodium bicarb produced. Okay, and they empty it in the duodenum. You can see the similar to the diagram, I would say, kind of like a review for you. Definitely, you're gonna have a question on those ducts. Locate them on the liver. Locate them on any of the models that we have. So look at those ducts. You see those two like a Y shape. So here is what I suggest. There is a Y, okay, and there is a Y. Correct? Yeah. Again, there is a Y, and there is a Y. So the first Y is made by right hepatic and left hepatic ducts. They merge, make common hepatic, which is the stem of the Y. Then the common hepatic merge with the cystic. You see the cystic that comes from the gallbladder and makes the common bile duct, which continue and opens at the same of pancreatic duct, where we're gonna have a sphincter surrounding it, and you call it hepatopancreatic ampulla of water. That's fine. Or this, I like, short term. If you put it on the diagram, sphincter of Oddi. That's the name of the guy. Sphincter of Oddi, hepatopancreatic sphincter, whatever you want to call it is fine. And you can see the ampulla here of water. Both merge together. You see how they merge and have this opening. So now you have the bile released here. You have the pancreatic enzymes released here. It's a major ampulla of water, like you see it here. It has a sphincter. Notice here that opening, guys. It has a smooth muscle surrounding it. Because if I don't need the enzymes from the pancreas, if I don't need the bile, why not just shutting it off? Keep it when you eat lipids, fat, all these things. So we functioning where your body is in need. You can see the accessory, the one I just mentioned, but it wasn't on the previous. You see accessory pancreatic duct open as a solo opening, different than the one that they combine together, but this can like additional. If, for example, you have a heavy meal and you need to digest the fat, the protein, and the sugar, because the pancreas has all the enzymes that can take care of those. It has pancreatic lipase. Notice the A's means enzyme. Pancreatic amylase deals with the sugar. Pancreatic lipase deals with the lipid. And pancreatic protease deals with the protein. So everything, we need the pancreas for everything. Even we have pancreatic nucleases. They deal with DNA and RNA of cells because those are chain of bases of amino acids. Remember that complex structure of your DNA and RNA? We need to break it down. We have cells, sometimes we renew it on a regular basis, see? Sometimes we have cells, either from the food that you eat or from your body regenerating new tissue. You have an ulcer in your mouth. Those are dead cells, you're gonna swallow them, correct? But you need to digest. So your pancreas is very important dealing with all these things. And you can see the major opening here with the sphincter of Oddi or ampulla of water, and the opening for accessory pancreatic duct, or they call it duct of Santorini, which is an Italian name, duct of Santorini. That's the name of the person who discovered. So if you put sphincter of Oddi on this one, I accept it, even on the upcoming, quiz, lab quiz on Thursday. We can see the gallbladder, hepatic duct. You can see the common hepatic duct. They should put common here, just not to confuse you, because we have left and right. They join together, make a common. You see the common join what? Cystic. You see the cystic bladder and make one common bile duct, opening all the way in the duodenum as you see it here. So that's actually the opening. That's the duodenum. You see the C shape? So that's the head of your pancreas, that's the body, and that's the tail. Tail extend all the way, touching your spleen. Yeah, it's a long tail, touching the spleen. So that's the pancreas. You can see the head, body, tail. Okay? Yeah, this is, okay, if I go back here, because I want to explain to you things that we've seen in the ER, where, especially in females, gallbladder stones are common in females, and I would say, let's see, 4 Fs. Who is at risk? 4 Fs. Okay. So the first one I said female. Yeah. As a female, you have a risk of having gallbladder stones. Rarely you're gonna see females. What's the other F? Because we need the 4 Fs. Female is the first one. What's the other F? Fat. Obesity. Risk you of getting what? Gallbladder stones. Third F. Familial. So if your mom has it as a female, you may have this problem.
Familia?
Familial, yes. The last F is 40. If you're above 40, also at risk. So if you have more of the Fs, that means more risk. I have to calculate now. So that's about gallbladder stones here. Now, what you're seeing in the ER, sometimes the gallbladder stones move and goes where? Maybe in the duct and causes the pain. And you go to the ER, give you muscle relaxant and painkiller and discharge you from the ER. That's not gonna be an issue. You're gonna go same day to your home. But when they're gonna tell you we have to let you stay in the hospital, admit you in the hospital, who can tell me? If the goldstone is where?
Oh, if it's in the,
Here, from the picture, I'm not asking
in the
you.
liver.
No, why liver?
If the gallstones are blocking the,
They're
Blocking the common bile duct.
Exactly, the main one, the common. Here is the common, you see it? If a stone moved from here, because gallbladder always contract, it's gonna expel those stones. You may have 20, 30, we've seen 20, 30 stones inside the gallbladder and they're quiet, they're silent. But sometimes one of them move, passing the cystic, and then obstruct the common bile duct somewhere. Now how I can tell? Pain is pain in both ways, whether it's in cystic duct or in common bile. Send the blood test for bilirubin. Because we said in the bile we have bilirubin, and if I have obstruction, it backfires back into the blood. You see? So we do a test, we send for bilirubin, bilirubin is high, we cannot let them go back home. So that's my key here. So they're gonna stay in the hospital and we should operate, because if I wait, the bilirubin goes up and up more and more, and that's a risk on the patient, okay? So it depends. If they give you injection and you go back home, that means it wasn't in the common bile duct. If you stay and admitted in the hospital for surgery, which we call it cholecystectomy, all of you heard about that term. So that means operation going to be done on you, and we can remove that stone from the common bile duct. And you're going to stay for about 3-4 days in the hospital, because we want to make sure all the drainage is no longer blood, it's only serous fluid, so they can close the area and let it that you go back.
Now, that's a cholecystectomy.
Cholecystectomy.
That's when removing the actual stones, right?
And the gallbladder itself.
I was gonna say, and the gallbladder
Yes.
itself. Now, what if, I know because gallbladder you can live without it and everything, and that's when the liver takes over for the whole workload of the bile, right?
Yes, but what, my question here, are you gonna digest the fat in this case?
No.
No. We will.
I mean, it
We'll
would be a
have
slower
less
rapid
diet.
breakdown.
You're gonna have this slow digestion.
Slow.
Okay, we see the pancreas has pancreatic lipase, but it's not gonna be enough because I said at the beginning, the bile is necessary here. Now, you're still making bile, but you're not storing bile.
So you have
Understand the difference.
eat
Your
slow,
liver cells, we
slowly.
didn't touch them. Hepatocytes make the bile, but we lost what? The storage, because we removed it. So you're still making bile, goes all the way, but if I have a fatty meal, I'm gonna suffer from that. So that's why they give you pills, which has some of the enzymes that can help you when you are about to eat what? A fatty meal. So those would be helpful in this case. But again, the only thing you're not storing bile. It's not a big deal. If you take care of yourself, you watch what you eat, you should be fine. Now, what else I want to say here? Okay, one of the things that hit the pancreas is pancreatic head cancer. So the head of the pancreas, unfortunately, the cancer starts in the head. And why I said it's dangerous? Because of this, okay? And because it starts in the head of the pancreas, and sometimes they come in with the pain. We think it's from the stomach, but it wasn't. We give them antacids in the ER, but it doesn't go away. Oh, it's something else. Because it's in the same region. They point here, you think of the stomach. So now we're gonna tell them, oh, we wanna take blood, send it to the lab, and check for pancreatic amylase. This is in pancreatitis. If the pancreas is inflamed, it shoots 5 times higher than normal. And when this comes back, they officially gonna tell you there is something wrong with your pancreas. And if it stays, they're gonna tell you, okay, we don't know, is it just inflammation or maybe cancer that inflamed, correct? It can be either one. So what they're gonna tell you, they schedule you for endoscopy. So they're gonna actually go all the way through your mouth with a tube, all the way until they go passing the pyloric sphincter, reaching the duodenum, and take a biopsy from where? From this opening. And punch, they call it punch biopsy. The same endoscope equipped with that. And then under guided screen, of course. So they take this and send it to the lab to see if there is cancerous cells. And if it's positive, that's bad news because this is deadly, to be honest. The pancreatic cancer is mostly deadly. And you actually heard the news about Steve Jobs, if you remember, when he had pancreatic cancer. He didn't last. He even tried, some herbs, different medications outside of the chemo, and decided to do it because he knew that a lot of people didn't survive. So it spread fast actually when we had a biopsy and this came positive. So that's what happened with the pancreatic cancer. Same thing here. That's the Y shape that we just talked about, you see? Yeah, it's the same, just summarize for you how to end up in the duodenum. Those are liver cells. So we're gonna stop at the liver. How about that? Enough for you? Yeah. What slide is this?
38.
38. Oh, it's
Or
not bad.
77.
We're halfway, so I can continue on Thursday. Right?
You can finish on Thursday.
Yeah, we can finish this on Thursday, definitely, yeah. And maybe start another beginning of introduction or something. All right? So take a break, come back, and we'll see you after break. I'll ask Alison to prepare tongue slide. And do you guys like to bring small, large intestine just to
Yeah.
review it? Yeah, I bring all digestives, 3 slices, and I have a liver here, and I will try to project for you all the models that we have written on them, the names. That's easy for you when you come doing your final lab. Okay? Okay, enjoy the break. And I'll check your homework after you come back from your break. No, the last 3? Yeah, all the 3. Yes, and then
Yeah, wait,
practice on
I,
the last 3.
the last 3 that were, what about all of these ones with the noses?
No, just the last 3.